Good afternoon. Thank you so much for joining us either in person or online. This is Foundations of Global Health in conjunction with the International Orthopedic Trauma Collaborative. I am Alexa Smith, and I am the Educational Exchange and Event Program Manager with the Office of International Programs. Just a little bit about our series. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. And that comes from the Consortium of Universities for Global Health. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians are international partners and our community partners. The series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. And our next session is right back here on Tuesday, February 24th. And now I will turn it over. You can put it on. I'm just holding it.
Hold it. Okay. Okay, hey everyone. My name is Lori Spiresweet. You've probably seen me kind of in and out around these lectures and kind of other things here. I'm going to just jump into this and then I'll get more into that. But this is nursing and the impact on the global orthopedic trauma epidemic. So this is me and Dr. Headings, as you can see. So I graduated nursing school in 2006. So coming up on 20 years of nursing this year. And I went to KU, so Rock Chalk Jayhawk, and I did my internship in the OR, which was like a 3-month stint in orthopedics, oddly enough. So my nurse that I was with did orthopedic surgery. So my background really was in orthopedics from the beginning. And then I started my career here at KU in the operating room. And at the same time, Dr. Heading started his career in the operating room in 2007. And I was a young nurse and he was a young physician starting his practice, and he needed a nurse and I needed a physician, and we had the fate of working together from the beginning, which has been wonderful. So now fast forward a couple years ago, Dr. Heading started this fellowship, and it became pretty clear to us that, training doctors, we would also need to be training nurses. So I kind of tagged along on that, and I'll get into more of that too, but I wanted to say that kind of up front because you see my face in other areas and not just like clinical. So I want to just kind of bridge that gap on like who I am for this organization, and my role has kind of grown, not just from like the nursing side, but also just helping the nonprofit side. So I've moved into that role, and that's why you see me kind of around in the other projects as well. So not just a clinical nurse for Dr. Headings anymore, but I do still work with him in the operating room 3 days a week. The poor guy. And Dr. Headings likes to say that my job as a nurse is to make him look good. So just bear with me. OR nurses don't tend to like the limelight. We definitely want to make our surgeons look good. So I'm not used to this. I love to talk, but yeah, just bear with me. Anyways, here's a little clip from our Instagram.
The beginning. They started us working in the evenings, which you kind of do a little bit of everything. You're a jack of all trades. It's a great way to learn, just get your skills in place. And so then I ended up switching to day shift. And when you work on day shift, you usually start working more with regular surgeons, regular scrub techs. I loved the patients. You see people from all walks of life who need help, and we get this wonderful opportunity to help fix them and get them back to regular life.
Okay.
I always knew I wanted to work in health.
Moving on here. Hold on. Here we go. Okay. So that's just me in a nutshell. So also just off the bat here, I think it's important to talk about nursing models of care versus physician models of care. This is something we all kind of know as we go through school, either in nursing school or med school. But these are things that we don't tend to talk about in the reality of clinical care. But I think it's important just to note, while we're here talking about it. So they're different in focus, but not in purpose, right? So we're all kind of trying to achieve the same goal here. There's a kind of difference in the experience and how we practice, but there's a shared goal. So you guys can kind of see, you guys know the medical models. Nursing models are going to be kind of more patient or person-centered. I'm going to go to the next one too. So how is this a person experiencing illness? How do we support them? These are the different models or the unit of care models. So again, we're looking at the unit of care differently, but they both matter. It's not you, it's me. Oh. So the medical model generally is going to be looking at the outcome, whereas the nursing model is also going to be looking at the people living with the disease. So is it sustainable? Is the care sustainable? Can they actually, do they understand it? So if that treatment is not sustainable for that patient, we need to redirect.
That's a really good slide. I'm just going to go back to that just a little bit. So if you ever see headbutting between doctors and nurses, the good thing about it, just look at those two different things. Doctors who were criticized for being insensitive, but look at our model. It's disease or condition. I consider myself a good physician when I go and diagnose something, come up with a treatment.
Also with that, and like laugh, they want me to periodically throughout. The mic is on this time. But so about like 70% of different errors that occur that are unexpected, that lead to harm, are from communication errors. And that doesn't just include like, okay, how are we talking to each other? But it's also that understanding that we have of one another's models, because if we're at odds with one another, then we can't really like have that communication, even if it's not through speaking and it's just like through our actions. So if we're learning about it right now as medical students, as you guys are sitting here, then that's going to end up improving our ability to provide equitable patient care in the future. But
I think that's such a good point too, is just
I knew I had an interest in the OR. And then KU is one of the only hospitals. Okay. Thank you. No, you're fine. So KU is one of the only hospitals in the area that will train new grads in the OR. So they have a special program. It usually lasts 6 to 7 months. It's a pretty extensive training program, and they train you to scrub and circulate. So that's another unique area. Usually ORs want to hire nurses with experience. So it's a great opportunity for new grads who are interested. Now to break it down, there's even, like I said earlier, there's 2 nursing roles, the scrub nurse and the circulating nurse. So here I have a picture of some people scrubbed into the sterile field and then a gal who's making little peace signs. So one of them is scrubbed in and sterile, and they're responsible for the sterile field. They're responsible what's happening at the sterile field, whether they're with they're just setting up. They'll set up the sterile field before the patient gets in. They're making sure they have all their instruments organized in a fashion that makes sense to them. They're going to make sure that everything is clean, not contaminated, because sometimes we open sets that might be contaminated with bioburden, or they had a hole in it or something like that. So we're making sure before we get the patient on the table that all those checks and balances were met. The OR nurse is going to be more kind of looking at the room as a whole. So she has a she aspect. She is helping with the sterile field, but she's also going to be communicating between interdisciplines. So she's making sure anesthesiology is accounted for in what they're doing, and from there, and then the patient looks good. She's communicating with surgery, anything that the surgeon might need that she has available.
She's the boss. Like when you walk into the room, this will help you out so much on your rotations. That circulating nurse is like the boss of that one. So sorry, she's the boss. I'll say that. So just know that she's the one that's like getting everything ready in that room. And if something doesn't happen in that room, who's held accountable? You. That's right. So like if you walk into a room, understand if you're doing something, maybe you don't understand what's going on in the room and you make the circulating nurse mad, it's because everything that happens in that room, basically it's on that circulating nurse's shoulder. So get along with your circulating nurse if you want to.
And a lot of this is done in between cases or at the beginning of the day. And we want to generally have a 30-minute window between cases. So it can be really rushed too. And I don't know that we always meet that, especially in trauma, but I will tell you 30 minutes is a short amount of time to get the room set up, to make sure all the communication is done. So I'm also communicating with like any sort of radiology thing that we may need. I'm checking to make sure consents are up to date and notes are signed. I'm going to make sure we have positioning devices, any labs that were required, any meds that are required. So it's kind of this orchestrated event. And then obviously I'm going to be looking at the patient. And then that's just the beginning part of surgery. So once we get a patient in the room, the circulating nurse is responsible for being at the bedside for anesthetic induction. So we help and assist during that stage. It's a really critical time during surgery. A lot can happen in that time. So we're always right there helping anesthesia. And then after the patient's asleep and comfortable, we will position them oftentimes before the surgeon gets in the room. So we need to be familiar with how to safely position a patient and in a way that's right for surgery, which can be complicated, especially in orthopedic trauma. And if they're comfortable, I need to make sure that that patient looks comfortable. All the lines and everything are accessible. If they need a Foley catheter, that kind of stuff. And then after that, we prep the site. So in orthopedics trauma, we're going to do a pre-scrub before we even sterilely prep it. And then we'll do a prep, and then we drape. And then I tell Dr. Headings we're ready, and he'll come into the room. And then, you're responsible for the patient during surgery as well. So you're paying attention to anesthesia, you're paying attention to your sterile field, making sure they don't need anything. I'm listening. I think hearing is one of the most important senses in the OR. I'm constantly listening. I can be having a conversation with you, and then I can hear Dr. Heading say something, and I'll know, right away that he needs something. I know, because I know exactly what's on the field. So if he says, I need XYZ, I already know it's not on the field. I'm just going to get it. So you're always listening, and you can hear the monitors. If I can hear if like something's happening to the patient. You're always listening. So yay, we've made a complete surgery, and Then we're going to be obviously helping at the end of surgery to wake the patient up and get them off the table. And that's another critical time that when they're coming out of anesthesia. It can take a minute. And we're also looking at, dressings and any sort of like, any issues with their skin integrity that might have happened during surgery, taking out any lines they don't need. And we're communicating with PACU nurses. So a lot of communication happening, a lot of moving parts. Okay, sorry, you guys, that was getting long-winded. So here's just a quick little rundown of kind of like what I was just talking about. And you can kind of see who's interacting with who in what ways. Okay, so there's nurses, but KU and at our OR, we have extra support people too, which is wonderful. So we have surgical support staff, S3s. They help us clean the room between cases, which is great. We have to clean the room, and they help us get supplies during the procedure if we need them to, which is great. We have unit coordinators, and they help. So I'll call them if I have like a need for like the next patient, because we're kind of always thinking ahead. So we're thinking what's coming next, or if Dr. Headings wants to move a patient, or if something's added on. We have team leaders who are specific to services. So we have our ortho team leader who helps. She's thinking about the next day, right? She's thinking about who needs what for the next day and how to organize it. She is also helping me if I need something during the case that I'm not that familiar with. They're an excellent resource. We have anesthesia techs. They help turn over anesthesia stuff between the cases. We have biomedical engineers. So if something were to happen with our equipment, then they come in and help, which is wonderful because I know quite a bit, but not enough to maintain all the equipment in the room. Radiology techs, they run the C-arms. I'm not able to do that. We have sterile processing techs downstairs. They clean everything for us. So again, major bonus for us. I don't have to clean that. We have PAs and nurse practitioners who also kind of help. And also, I did not include, but I want to include, we have med students here at KU. And this is one of my favorite parts of working in KU. When we get new nurses or new people coming to the OR, I'm like, hey, look, one of my favorite things about this place is working with students. I love that it's a teaching hospital. I love working with med students. I can't wait every time we get a new med student in. It's really one of my favorite parts. Being able to teach and help teach you all is truly one of my favorite things, and getting to know you all is such a fun aspect. And same with residents. I love interacting with the residents. I learn a lot as well. It's a great opportunity to kind of have that bi-directional feedback too, because med students are asking great questions and they're not afraid to ask questions. And it's just the hierarchy is a little bit different when you have a resident. They might not be as comfortable saying, hey, why are you doing this? Or they are expected to know a little bit more, right? So a med student coming in has great questions, and I love that perspective.
And Lori, I just have to say, you can get overwhelmed by looking at all this staff in the operating room. When you walk into the operating room, to use an analogy, it's kind of like an ant colony. You've got things are happening so quickly. Everybody's got a very specific job. You don't want to get in the way. You want to be helpful, right? You can really tank yourself on a surgery rotation by just getting in the wrong way and, knocking somebody's sterility out or something like that. So, but if you're lucky enough to have a circulator like Lori in your room, boy, latch on, not too tight, let her do her job, but latch on to her. She'll kind of help you kind of figure out what's going on so you can be helpful. Then you'll shine. You'll just shine because there's a lot of stuff going on in the OR. Yeah.
Yeah, thank you for that. All right, so now we're going to talk about orthopedic surgical nursing in particular. So you can kind of see here that there's quite a bit of trays here stacked up on this set. So orthopedics is a highly specialized kind of field in the OR for a nurse's perspective. Orthopedics has a lot of specialty equipment, implants, supplies, instruments, and it could be hard work. It's physically laborious. You can see those trays they're really heavy. That we have to lift them and put them on. And a lot of times we're lifting multiple times throughout the case. We have to wear lead aprons for x-ray, and that can be physically taxing. So we also have a lot of equipment. Here's a setup too, real quick. Just kind of this looks like it's for a joint. But you can kind of see that's a lot of really kind of, you guys are probably pretty familiar with basic medical instruments, and that's some highly specialized instruments. And you can imagine a surgeon doesn't want to explain every single one of these to their team every single day. So you got to know what you're doing. All right, so here's some of the positioning devices. You can kind of see this is positioning devices that we use in surgery for orthopedics. There's the lead aprons. That's a tourniquet machine. So these are all things that we need to know how to use and operate. Here's just like our basic stuff that we need to understand just for this surgery: suction, cautery, bear hugger, more positioning, more equipment, specialty equipment that we need to know. Here's just a rack of like, this is just the spine stuff. So you can get an idea of like, this is just spine extra instruments. That's just spine, you guys. I had a video of like the trauma stuff too, but I couldn't find it. So
yeah, because there's probably more trauma stuff.
For sure. There's like multiple rows of trauma stuff. And we need to be aware of what all of that is, like, because it can happen that you're in the middle of a case and they say, I need such and such set. And you can't be looking like you're deer in headlights at that moment. So here's some more of the equipment, little mini C-arms, arthroscopy towers. That whole aisle is orthopedic stuff. These are some of the beds that we have to know how to use. It can be really overwhelming, as you can imagine, especially as a newer nurse. But yeah, this is like a spider bed. It's for shoulders. This is our old traction table that we actually just sent off to Zambia. And then, oh wait, no, that's a different one. That's a different one. Anyways, similar, and then this is just a room full of like beds and tables and stuff. So that we use as kind of like a closet. Peel packed, just extra individual instruments for orthopedics. Yeah, you can you're getting the idea here. It's a lot of stuff. And one of the hardest things about coming into this environment is just learning where things are and what things are. So, Dr. Heidinger slide's not on here.
Oh, darn it.
Don't know what happened. It was supposed to be here. So
okay.
I don't know if you
I
want
can say it in a nutshell. I had a slide and basically what it went through was everything that it takes to do a surgery. So, but it's kind of redundant. And now you've done such a good job here. But here's the point. When you look at what it takes to do good surgery, can you now understand why there's a great disparity throughout the world in terms of delivering surgical care? Can you understand why a poor country can't deliver surgical care? I mean, think about all the resources and money it takes to do this, right? And so that's why I said you all are at the forefront of something occurring in medicine. How do we make surgery available to everybody? Vaccines, this has pretty much been done. You can get vaccines in almost every country in the world. And if you think about the AIDS epidemic, how, we were able to, you had in Zambia where we were going pretty soon, 1 in 3 people there died as a result of HIV. That's been reversed in large part due to our interventions, but that's a medical disease. We learned how to deliver these medications in a thoughtful fashion to these people. What you see here is the equivalent of a medication for a medical disease. This is our treatment for surgical disease, and we want to bring this to everybody. So, and what we wanted to bring out in this lecture was that unlike, say, with other specialties, this one is highly dependent on nursing. I mean, when you look at everything that's up there, what I do is I go through scalpels. You would not believe how many scalpels there are. There's tons of different types of scalpels. There's tons of different types of scalpel handles. There's tons of different blades. There's so many different types of retractors. There's so many different types of positioning devices. There's so many different types of implants. You've seen all that. You know who puts that all together? I don't have time to do that. I'm seeing patients. You have to have a good surgical team. That's Lori, or your nurse is making all of that happen for you. So you walk into the room and it's there. And
here, I found your slide.
Where is it? Okay. Okay, here it is. Well, now we'll go through this quick.
Yeah.
But here it is. Why is it not working? Oh, here it is. You need a table. You need a back table. They're going to set it up for you. Here's your Mayo. It needs to be set up. Why does that matter? Because when you're in surgery and somebody could be dying or bleeding out, you don't say, hey, what's that one thing that I use for this time? You need it right away, right? That needs to be there for you. So this needs to be all set up. So when you call for it, it's there. It's in, and somebody can put it in your hand quickly. You need good suction. There's different types of suctions. You need cadre. There's different types of cadre. You want the type you want. What size knife blade do you want? What type of knife blade do you want? What type of retractor do you want? There's plenty of retractors. What type of bone temp? What type of pituitary? What type of lamina spreader? What type of, this retractor or bone reduction clamp? And then what type of set? Do you see this? There's so much. I would never do any surgery if I had to do this. This is a job in and of itself. So, it's just here to make the point. What type of drill do you want? What type of C-arm and imaging device do you want? Do you need a headlight? And that's just the tip of the iceberg of what the OR nurse does for the operating team. Okay? Unequivocally, surgically cannot occur without nurses. They are a necessary part of the team. Any attempt to address the existing disparity in trauma care worldwide must have nursing education and equipping a part of its foundation. Hence why we have a nursing fellowship, right? We can train fellows here, but when they go back, if they don't have nurses that can work with them, this is just not going to happen. So, and that was the point of my slide. And the other thing is, it's very subspecialized. It's not like you can just have a nurse go through nursing school and then they go do this. They need this type of specialized training.
Yeah. So go ahead.
Could you just talk some about your experience when you've had a nurse who's maybe like not as confident in their ability to do this yet?
Yeah. This is why surgeons have to go to anger management classes. It's the truth. No, it's the truth. We're all human beings. You've got somebody's life in your hands. And the unqualified nurse who, for that nurse probably shouldn't have been put in your room. But the person who's going to talk to the family if something went bad is not going to be that nurse. It's going to be you. There is a lot of weight on your shoulder. I just thought I've been doing this almost 20 years. And there's a lot of anxiety in my clinic today. I mean, disability is on the line or people's lives on their lines. You carry a load and it's really heightened in the operating room, right? So if you have a good nurse who knows what she's doing, it just unloads you. It just does. And when you don't, it really could mean the outcome of a bad or good outcome from the surgery. It can.
Yeah. So one thing too, just to build on that too. So orthopedics is generally a high anxiety specialty for nurses. Nurses generally do not want to work in orthopedics, and you can see why. It's very overwhelming. And a lot can go wrong if you don't know something.
And to be very applicable, because we want everybody, if you're interested in this, if you're here taking extra time to be at this lecture, I'm just already biased. I think you're going to make a great physician or nurse or whatever your specialty you're in. So we want you guys to shine. So take this to heart. When you're a third year, you'll kind of be a fly on the wall. But if you come back and do your sub-I at your institution, those nurses that you rub shoulders with as a third year, if they liked you, when you come back for your sub-I, they're going to make you shine. And you're going to be put into a room and told to set it up. Are you going to remember all these retractors and everything that has to be there? No, but if your nursing team likes you, they will make you look so good. So I'm telling you, just take it to heart.
Yeah, it's true. And some surgeons will quiz you too. So Dr. Hennings isn't really like that, but
tell you the questions of the surgeon.
Yeah.
They'll give you the cheat code.
Yeah. So yeah, we can help you. But so anyways, orthopedics is one of those particular fields that can have it's funny. It's like you either love it and you're like a dinosaur and you're there forever, or they're turned over really quick in orthopedics. So that is something that I'll get to this too, that we do see this internationally as well. It's something that translates kind of universally, that it's a difficult service. And so that's frustrating for physicians as well, right? If they're constantly having new nurses coming in that barely know what they're doing. And then of course that just increases the anxiety for nurses if their surgical team is upset with them, which can happen, right? There's a lot that can go wrong. And over time you do build that confidence, and obviously extra training is something that we find very valuable. So, and I was lucky enough to start with Dr. Headings, who we kind of learned together. So that was lucky for me. I felt like we just kind of like grew together, you know. Okay, so now to talk about ortho nursing at Abbott Hospital in Ethiopia. So let's take this now to Africa. So nursing in Africa, one of my first experiences when I went over there, it's shockingly similar. They're saying a lot of the same things that I'm saying. They find certain things frustrating, the same things I find. They're doing the same things. What's different is the context. So nurses also, remember that long list of support staff. Nurses in Ethiopia are doing all of that. They do all of that on top of just what I do as a circulating nurse or scrub nurse. So they're managing their own schedules as well. They're their own managers. They are managing implants. They're figuring out that kind of stuff. They're the team leaders. They're the unit secretaries. They're getting patients ready. They're doing all of that. So imagine, right? So then also they do feel that same insecurity that new nurses feel in orthopedics, or even old nurses feel in orthopedics. It's still an anxiety provoking field for them. They have to do it. That's what they do there, right? They're doing orthopedic trauma. So, but they do still have that anxiety. And how do we alleviate that anxiety? Well, you know, through practice and education. So nurses also have to function with less there. So I have everything I need pretty much, or I know how to get it. Nurses there have far less, less resources, less implants, less support staff. Here's some pictures. So that's their entire orthopedic section. But remember the spine section, this is just their section of instruments. You can see that cautery machine there. It's got a pad that they just reuse over and over again on every patient. We reuse those. I'm sorry, we get new ones for our patients. That OR bed is actually broken. That was a broken OR bed that I'm sure they have to use. So she goes through all her implants herself, whereas I have implant reps. That's another person that I have that supports me that I didn't put on the list, but she goes through all her own implants and picks out what she needs. She's running the C-arm. There's their lead. It's extremely heavy and uncomfortable. You can see they just register their implants in a paper book. I use the EMR. They have cloth drapes. Okay, so what does research tell us? There's a ton of research out there as far as kind of supporting what I'm saying here as far as like education wise. I can go through it, but this is just a little fact sheet that the AACN put out, and it's basically going over all of it. So I'm just going to kind of scroll through this just to show that it's well documented, that yes, education helps. It's just a well-known fact. Well established that yes, education helps nursing. Okay. Yay. Okay, so what about research in Africa? It's the same. I'm sure you can, guess. A lot of the studies come out the same. So studies from Nigeria and across sub-Saharan Africa show that higher nursing education levels are associated with improved patient outcomes and safer care. The challenge, of course, is access. So there's limited resources and shortage of trained educators that restrict opportunities. We're trying to come up with innovative solutions like blended learning and targeted perioperative training programs. Research indicates that enhancing nursing education in Africa positively impacts patient outcomes. Continue on, we know that we here at KU, like, what do we know as far as like what we've experienced? We like to bridge formal research with lived experience. So we're lucky enough to have experienced doctors and nurses who kind of live and breathe that research every day. And we can apply that to how we train our nurses and surgeons, and also how we're training internationally. So surgeons, consistently report that knowledgeable and confident nurses improve the communication, the efficiency, the workflow, and that reduces patient wait times, time under anesthesia, overall frustration in the OR. The education doesn't just benefit patients either. It does improve general collaboration with surgeons and overall team morale, which research also tells us that increases patient outcomes when the surgical team is happy and works collaboratively together. So, and anecdotally, we know here at KU that it does increase frustration when nurses are not educated. Oh, okay, so this, you can see here, she's got all her plates and screws and everything. This was me in a big setup, and I moved the Mayo and I tipped over all my screws. So you kind of have to be able to, react and be able to adjust. She's already had hers already in like a pan. You can see they have to dig theirs out of the pan. So I'm lucky that I just accidentally tipped mine. There's your slide, Dr. Headings. All right, so here's just some more just research stuff. You can kind of see, just elaborating on what I've been talking about, and that simulation-based learning and problem-based learning is also an interesting thing that we might, look to tapping into if we're not able to train directly. We have this really awesome simulation that we use here at KU for Code Blues, and it's like incredible. I had the opportunity to do it, and those real life kind of simulations that they put you through can be incredibly helpful, even for people like me who have a lot of experience. And thankfully, I don't get to do a lot of Code Blues, but they do happen. And as you are going on in your practice, things change it too. Like things change in how you run a Code Blue. And if I'm not updated on that, then that can have a bad patient outcome. So what can we do? How do we shift our experience into action? Well, we can start orthopedic trauma fellowship programs, which we did, and that has grown, as you all know. So that's kind of what we're doing. We started a six-week observership program where we have a nurse who comes to KU and observes with us, and we've been fortunate to have one fellow come over. Future, he's on the call. So I'm going to keep kind of rolling here so we can get to him. And what are we doing at ATI? Well, we're educating and equipping. So yep, just to hound out that point, we know we need to teach them. So we're going over there as well. And when we visit their home countries, we're able to observe them, and we can kind of figure out how to tailor their education needs and figure out how we can best serve them. And then also when we go over there, we're able to tailor how we change our practice and how we go about treating our patients here, and how I change my clinical practice kind of in response to that. Orthopedics is growing really rapidly over there, so it's always good to kind of check in and see what they're doing there. Let's see. Oh yeah, so then also obviously we can help equip. So when we go over there, we can kind of figure out what their needs are. What specifically can we help provide them, whether it's implants, tables, beds, drills. What do they need that we can prioritize to send to them that can help improve outcomes? And one of the other things that we're doing is creating awareness. So we can help spread this around, teach people. It's funny because I've been doing this for 20 years and no one really knows what I do. I'll say, hey, I work in orthopedic trauma. When people ask me what I do, and they go, oh yeah. Like you're fixing, so like I broke my head. Like, would you help me with that? And I'm like, no. oh, you're like in the ER. You do emergency trauma. You're doing trauma in the ER. No, I'm not in the ER. I'm doing surgery. It's orthopedics. It's bones. And people, it's just a hard thing to grasp. And not only that, but like even within the OR, it's like, or even nursing, we kind of don't even really know. It's one of those fields that doesn't get a lot of visibility. So it's hard to explain to people exactly what I do. And then now on top of that, we want to create awareness for the orthopedic trauma in low to middle income countries and the epidemic that's happening. So we want to create awareness with that. That's another way that we can help serve our partners in Africa as nurses and doctors. So we're trying to make documentaries, we have social media campaigns, and we want to get this out so people can learn. General people, not just medical or nurses. We want everyone to learn about this. So got a couple more here. All right, this is just a little clip from the documentary. All right, now future, I don't know if he's on the call or if anyone has any questions. I've got our nurse fellow on the call. I don't know how to do it, Alexa.
No, Kimberly had a question.
Yeah, Kim, I'm glad you mentioned this about the BSN. So there's a lot of the research is focused on the bachelor's, just increasing um, nurses' education to the bachelor's level. And that is important, but I think there's a lot of value too in just increasing educational experiences outside of the academic setting as well, just like those simulation based or these training methods to just kind of getting creative, because we won't be able to provide a bachelor's degree for every nurse that we're training overseas or something equivalent. So these hands-on experiences and observational experiences are really important as well as far as an education tool. Just like what I was saying, as far as like it's important for even me to kind of keep up with simulation based and other special opportunities for education.
Yeah, and that was kind of my question. What I was saying is, how do you train U.S. citizens who graduate with a BSN to be prepared for orthopedic surgery, which is so specialized? How is that done?
Yeah, so when we have like I was saying earlier, they've got that 6 to 7 month period where they're training and they go through all the service lines. And then if you end up in the orthopedic service, you do get a little bit of extra time. It is kind of trial by fire sometimes as well, unfortunately. So my advice too is when we have new people coming into the service, I tell them, know your resources, know who you can talk to, and lean on them. And I do feel like that's works really well for us at KU. We on the orthopedic team, I feel like are particularly supportive of new people coming in. And so it's important, I think, for us just as experienced nurses also to take that on. So,
Futures.
All right. Hey, Future.
Hey, Lori. Hi.
How are you doing? Did you want to, if you want to just jump in and kind of share your experience or however you want to go, we'd love to hear from you.
Oh, that's awesome. I don't know. Am I audible enough?
Yes, we can hear you great.
That's fine. So my name is Future. I came to Kansas University, I think that was around February. Easy, 2025. Yeah, so I've been practicing for about 13 years now in the OR. So it's been quite interesting. You know, I came to learn, it was a work exchange program. So looking at how we work here in Zambia and Africa at large and how America I know works is quite similar, like the way Lori said. We have shared goals, but we kind of differ in the resources that we provide this work from. For example, US is rich in terms of instruments. They have almost everything. In Africa, like the way she has put it, we quite have scarce instruments, and most of our work, we improvise a lot. So what's important is, despite the improvisation, we all share the common goal, which is, seeing that patient happy, seeing that surgery successful. So I quite learned a lot. And me right now, I have broader aspect of seeing how USA works and seeing how Africa works and Zambia in particular. So right now, I can testify that that testimony, and I'm one of the people that have, benefited from the Redford Fellowship. And also I'm one of the people, so amongst the other doctors, I think I was the first nursing fellow that, came to Kansas. So I've learned quite a lot, and the knowledge that I learned there, I've been using it in my daily life here. We quite have a lot of orthopedic trauma here in Zambia, a lot of them. And what usually, gives us problems is instruments we don't have. And most of the instruments, our author says that we use here, we quite like import them. And importing needs a lot of funding. But in terms of traumas, we have a lot of surgery. So with the little instrument that we import from overseas, we're able to do a lot of fractures, a lot of surgeries, a lot of trauma cases. But now, with the knowledge that we have, and we are so thankful that this program has even, helped in the Office of International Programs, the IOTC, the ATI, African Trauma Initiative, all these programs coming in. We are so happy that at least we have seen, this program has yielded so much that they're going to provide us with, a lot of instruments. I'm sure, the container is almost on the way. And now we're going to have about 6 operating, room theaters. Please, can you clap for me? For us, that's like a dream come true. So we are going to have a lot of instruments now, and this one will ease our surgery so much. And we are so happy. We can't wait to have that container here in Zambia. It is going to ease our work so much. And thank you to Rory to give me this platform, to the Office International Programs, Dr. Headings, and the whole organizers that help us, get to there. Also, Dr. Kinda, that are helping putting all these programs together for us at the end of the day to have these instruments and be able to do our surgery, with the decent and the instruments that the patient needs. So we thank you so much, and thanks for giving me this platform. We are still following, and together we can. Thank you.
Well, thank you, Future. It's so good to see you. I miss you.
Thank you so much.
I can't wait to see you soon. And Dr. Patrick. Yeah, so did anyone have any questions?
I had a question. I was wondering what your guys' approach is when you're having nursing fellows and just general fellows come over from a low resource environment to a high resource environment, and like what you are training them here to do for that transition back as well.
Yeah, so it's a great question. So with the physician side, they have a year-long program, so their program's a little bit different. They get to do a little bit more as far as like research and hands-on practice with cadavers. With Future, I was only able to have 6 weeks with him, so his was just an observership. So he basically just got to observe. He did get to scrub in with me and go through all the processes. So the value of that, I find, is like if we're training physicians for a year on state-of-the-art technologies and procedures, and then Dr. Patrick takes that back to his home country, and if his nurses are not didn't have that on the ground observation also, it could be harder for them to kind of keep up to speed. And in Zambia too, nurses are doing a lot more kind of hands-on as far as like assisting. There's not PAs, there's not nurse practitioners, that kind of stuff. So Future did a lot of assisting as well. So he kind of behaved a lot like a resident and was able to do a little bit more. So for him to see those firsthand, I think to take back to his home country is invaluable. And then kind of like what Kim was saying, then he can then train his fellow nurses, right, too. And it's like, this is how this is going to go. This is how we do this. And so for me, Future, I don't know if you want to kind of elaborate on your experience on how you kind of took away anything from just observing.
Yeah, so basically it's important, you know, I was coming there already having this background of something that I've been doing for the past, 13 years, and coming in to blend to an environment where they have a lot of instrument. Sometimes I was just like, wow, I wish we could have this at home. But blending in actually was much easier that side, because some of the things that I didn't see, physically before, I was able to see, that side. So blending in is so easier, such that there you have everything. In here, even where you improvise, you are kind of like relating, oh, if I was back in Zambia, in case of these instruments, would have used this. But in here, they have, a lot of instruments. So you can kind of use the right instrument at the right time. Other than here, where, for example, I'll give an example. We don't have a power saw. If we need to cut a bone, for example, we use, for example, a bone chisel or an osteotome to cut, a bone. But there, you have, a power saw and a drill. So it's very easier to cut when you are working, because of, availability of instruments. That side is so easier. But here where we improvise is quite, challenging. But in terms of blending in, I would say there it was so much easier than here. So for me, it was something very easy that side.
Yeah, I think you brought up such a good point too. So we are shipping a container of all of this stuff to them. A lot of that specialized equipment you saw, we're shipping over to Zambia. So now Future already has kind of a leg up as far as like knowing what to expect when it gets there, and he can teach the other nurses. And Future, you brought up another great point that I think when you start working, you talked about improvising, and we don't have to improvise a lot here at KU, thank goodness. But nurses with experience, this is kind of one of the other things about having a nurse that's experienced, is there are times where you do have to be creative. And if you can kind of tell that Future was like, hey, you know what, I integrated pretty easily because he has experience. And when you are used to certain aspects of kind of jumping into things that are kind of crisis or chaos situations where you kind of have to be quick thinking, having experience really does help that transition pretty easily. And you know how to communicate with a surgeon if you don't have what they need. You know how to kind of take accountability for that. You know how to respond and how to help make adjustments if there needs to be something, a change in the plan in a critical point. So, he's just speaking to his experience here, saying that it was actually pretty easy for him to flow into that. So, yeah. Any other questions for Future?
was great presentation. So I like you saying doing more with less, and I'm sure many practitioners, including nurses in Africa, do that. My question is, they come in and get into the fellowship and so forth. How do you keep up or keep up abreast with the growing changes that occur once they get training here?
Yeah, so it's a great question. So I know this is similar to Dr. Headings too. We just have to keep that relationship going for as long as we can. So we will routinely, visit them in Zambia and make sure that their educational needs are met, and that we can't, if there's something we can do to help them on the ground there, as far as like transitioning with new procedures, new instruments, that we're kind of always filling that gap for them, staying in the loop on what's happening there, keeping them kind of centered to what we're doing. So we always are in conversation with them. So as we were doing the shipping container, every time I was at the warehouse, I was talking to Future and talking to Dr. Patrick. So they were really leading a lot of that directly, so that we're meeting their needs. So keeping that bidirectional relationship ongoing forever. You're stuck with us, Future.
The other thing is research. Yeah, research to give us the knowledge of what they're treating, what their outcomes are, and then help that helps our understanding in terms of like next steps to improve things.
All right. Well, Future, thank you so much. I'm so excited we get to see you in a couple weeks. Thank you for being on. Thank you all for listening. It was great talking to you. Oh, and then also here, God. Here's some pictures of their ORs this is Zambia. These are from Future. So you can kind of see it's similar to what they're doing in Ethiopia. We're using the cautery tips, that kind of stuff. So yeah, there's just some Zambia pictures. So anyways, thank you all. Have such a great day.